Bismillahirrahmanirrahim. Today we will have case quiz number 75. Case data: 55 years old female complaining of 5-year history of pain and swelling in her hands and feet with bilateral numbness and tingling in the median nerve distribution. She had gained 10 kg in weight over the same period of time and developed type 2 diabetes. She attributed increasing fatigue to poor sleep quality because of backache and to snoring. Examinations show weight is 80 kg with a body mass index of 35.2 kg per meter square. Blood pressure is elevated 150 over 100. Kyphosis and painful spinal movements. Hand joint tenderness with generalized hand swelling and coarse thickened skin. Wrist, knees, and ankles were hypermobile. Investigations showed normal CBC, normal inflammatory markers, ESR and CRP, negative rheumatoid factor and anti-CCP, normal sodium and potassium, creatinine within normal, total calcium mildly elevated 2.7 millimole per liter, phosphate within lower than normal, ALT, alkaline phosphatase and albumin all were within normal range, TSH normal, parathormone mildly elevated, so increased calcium, increased parathormone hormone and decreased phosphate. Hand X-ray are shown in the following table. This is the hand X-ray of this patient. So, what is the diagnosis? The answer is, take a breath and then see the answer. The answer is acromegaly. Acromegaly. In fact, acromegaly is not the only diagnosis for this case. This case had a differential diagnosis of what is called metabolic causes of arthropathy. Metabolic causes of arthropathy include hypothyroidism, hyperthyroidism, diabetes, diffuse idiopathic skeletal hyperostosis or DISH syndrome, primary hyperlipidemia, hemochromatosis, and finally acromegaly. Hypothyroidism should be considered in all patients with carpal tunnel syndrome. It may occur in up to 10% of cases and is due to peripheral tissue edema in the wrist. It would also account for the patient's weight gain, fatigue, and skin changes. Thyroid acropathy is a skeletal abnormality specific to Graves' disease. It is painless swelling of the fingers and toe, which may be associated with clubbing and periostitis. Diabetes may develop a number of joint-related problems. Diabetic arthropathy is most common in type 1 diabetes, but may occur also in type 2 diabetes. Patients develop soft tissue contractures that limit extension of the MCBs and interphalangeal joints without evidence of intra-articular or muscle inflammation. Patients with diabetic osteoarthropathy develop destructive lytic joint lesion in association with peripheral neuropathy in type 2 diabetes. Hyperostotic spondylosis or DISH syndrome are more common although not confined to type 2 diabetes. So DISH syndrome is more common in type 2 diabetes but may also occur without type 2 diabetes. Dish syndrome is caused by a widespread new bone formation with general ossification of ligaments and tendons, especially of the anterior longitudinal ligament of the spine. It is most characteristic in the thoracic spine, but may also cause stiffness and arthropathy in the peripheral joint with reduced flexion of the fingers. Its association with the metabolic syndrome is thought to be related to hyperinsulinemia and distribution of growth hormone. Disturbance of growth hormone. Primary hyperlipidemias are rarely associated with arthritis. Tendinous xanthomas are recognized feature of some forms of familiar hypercholesterolemias. Hemochromatosis is an inherited disease where increased iron absorption results in iron loading of tissues. It presents with fatigue and asymmetrical arthropathy in middle-aged patients. Liver abnormalities are demonstrated by chronic ALT elevation, and type 2 diabetes may occur. It characteristically causes osteoarthritis of the second and third MCB joints, but can affect other joints. Finally, acromegaly. The most likely diagnosis of this case is acromegaly. This patient had developed arthralgia with bilateral carpal tunnel syndrome, weight gain, diabetes, and hypertension. She had normal thyroid function test. She was hypercalcemic with a normal or mildly elevated parathormone. The diagnosis of acromegaly was confirmed by a raised insulin-like growth factor of 78.4 nanomole per liter and failure of growth hormone to suppress during glucose tolerance test. Acromegaly is caused by hypersecretion of growth hormone from pituitary adenoma resulting in elevated IGF-1. Both hormones contribute to the features of the disease. It is rare with a prevalence of 50 to 70 cases per million and an incidence of 3 to 4 new cases per million per year. Characteristic changes caused by tissue overgrowth include coarsened facial features, exaggerated growth of hands and feet, soft tissue hypertrophy, and macroglossia. Thickening of the skin is a manifestation of the effect of growth hormone on collagen tissue. There is softening and thickening of the capsular and ligamentous structures, resulting in joint laxity. Metabolic consequences include increased insulin resistance and hypercalcemia. Poor quality sleep and snoring are commonly reported. Increased mortality is due to cardiovascular, cerebrovascular, and respiratory diseases. The X-ray of the patient's hand shows soft tissue thickening, increased joint space, and enlargement and tufting of the terminal phalanges. An MRI of her pituitary fossa demonstrated a pituitary adenoma. Heel pad thickening demonstrated on lateral radiograph is also a confirmatory sign. Joint space widening is most frequently observed in the knees and in the MCB and IB joints. The epiphysis may undergo squaring and develop small osteophyte on the edges of the articular surface, especially in the MCB joints. Acromegaly is characterized by new bone formation and by subcutaneous soft tissue and cartilage thickening. Axial arthropathy is a common finding and may affect the whole spine. Imaging of the spine demonstrates widened intervertebral spaces, vertebral enlargement, and osteophyte formation with calcification of the intervertebral ligaments, resulting in resembling the changes observed in Dish syndrome. Management of acromegaly-induced arthropathy. Arthropathy is a well-established feature of acromegaly and may be the first presentation of the disease. Joint symptoms or signs occur in 70% of the patients. Acromegalic arthropathy has a characteristic biphasic presentation. In the first phase, soft tissue and cartilage hypertrophy result in joint widening and hypermobility. Chronic secretion of growth hormones stimulate production of both circulating and local cartilage IGF-1. This induces chondrocyte proliferation and cartilage matrix synthesis, with cartilage thickening, which can be demonstrated by ultrasound. Growth hormone causes growth of fibroblast and collagen formation with enlargement of ligaments and joint laxity. Bilateral carpal tunnel syndrome frequently occurs and is caused by both compression and hypertrophy of the median nerve. With time, the second poor quality cartilage wears unevenly and fissures form, leading to exposure of subchondral bone. Joint stability is compromised by ligament laxity and synovial hypertrophy with effusion. Secondary osteoarthritic changes affect both axial and peripheral joints, especially weight-bearing joints, and may be severe. The initial treatment of acromegaly is with transsphenoidal surgery to remove the pituitary tumor. Radiotherapy and medical treatment with somatostatin analog such as octreotide, a long-acting analog of somatostatin, or bigvizomant, GH antagonist may be required. Bigvizomant, the name of the drug. Reversal of the cartilage widening has been demonstrated with ultrasound. Surgical carpal tunnel decompression may be required in some cases. Although the first stage of acromegalic arthropathy may be reversible, secondary osteoarthritic changes may cause severe joint disease affecting both axial and appendicular skeleton. This should be managed with analgesia, physiotherapy, occupational therapy, and orthotics before consideration of joint replacement. The use of non-steroidal anti-inflammatory drugs is relatively contraindicated in view of the increased risk of cardiovascular disease. 35% of patients with acromegaly develop hypertension. Borderline or raised serum calcium may occur in acromegaly and is attributed to vitamin D activation by growth hormone independence of the parathormone. However, the most common reason of hypercalcemia in acromegaly, occurring in 5 to 10% of patients, is parathyroid secreting adenoma and is associated with multiple endocrine neoplasia 1, which is called MIN1 syndrome. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 76. Wassalamu alaikum wa rahmatullahi wa barakatuh.